Welcome to this explainer. Okay, today we're tackling a silent crisis that is happening across health systems right this very second. We usually think of medical failures as, say, an incorrect diagnosis or maybe a lack of hospital beds, but there's a much more insidious threat hiding in plain sight. Today we're going to explore how completely invisible information architecture failures, these massive systemic data gaps, are actively harming patients. We'll look at the severe consequences of fragmented care, why genuinely brilliant doctors are forced to operate in the dark, and how a totally new infrastructural approach could finally fix this broken picture.
Let's dive right in. To really grasp the emotional and physical toll this takes on patients, we have to look at the terrifying reality of navigating fragmented care pathways totally alone. This quote here, it comes from the story of Amara, a patient who literally had to cross-check her own cardiovascular and psychiatric medications at midnight because no single doctor knew she was taking both. It captures this deep systemic anxiety so perfectly. When the healthcare system can't hold a patient's complete medical history together, the burden of being that central information hub falls squarely on the patient. And let's be honest, they are usually the person least equipped to clinically manage that intersection.
Let's zoom in on a woman named Chidinma to see exactly how this fragmentation plays out in real life. Picture Chidinma. She's a 58-year-old retired secondary school principal in Enugu, Nigeria. She spent 35 years of her life managing incredibly complex institutions. But now, she finds herself inside a health system that just can't do what she did. It simply cannot hold itself together. She's managing 4 conditions: hypertension, type 2 diabetes, early-stage chronic kidney disease, and osteoarthritis. And here's the crucial part. These are managed across 4 completely disconnected clinical records.
So Chidinma is seeing a cardiologist, a diabetologist, a kidney specialist, and an orthopedic specialist. Now put yourself in the shoes of any one of those doctors for a second. Her cardiologist is incredibly competent, right? But they have zero clue what her orthopedic specialist just prescribed. Her kidney specialist has never even seen her full medication list. No single provider has ever reviewed her complete regimen at the same time. For the doctors, it's incredibly frustrating. They're highly skilled professionals forced to make huge treatment decisions based entirely on tiny fragments of a patient's life. It creates this compounding risk with every single new appointment.
And here is where we see the physical toll of that architectural failure. Recently, Chidinma developed some new symptoms and went to her GP. Well, because her GP couldn't see her kidney specialist's notes, or the anti-inflammatories her orthopedic specialist gave her, the GP prescribed a new medication. And the result? That new drug interacted with 2 of her existing medications. Chidinma suffered a severe, entirely preventable drug error that landed her straight in the teaching hospital. The craziest part is, the information to prevent this existed. It was just locked away in 4 totally disconnected silos.
Now consider Fatuma. She's a 47-year-old hotel manager in Mombasa, Kenya. In her professional life, she handles relentless operational complexity like it's nothing. But in her health life, she is navigating absolute chaos. She has diabetes, hypertension, and a thyroid condition. And despite getting regular care, her diabetes outcomes are fluctuating wildly. And it's happening in a pattern that absolutely nobody on her local care team can explain.
The mystery is finally solved when we look at the geographical fragmentation of her care. You see, Fatuma's thyroid specialist is all the way in Nairobi, while her diabetes clinic is in Mombasa. Her thyroid medication actively affects her blood sugar levels. But because her Mombasa diabetes team cannot see her Nairobi thyroid specialist records, they don't even know she's taking it. They are out there desperately adjusting her insulin to compensate for an invisible variable.
And this brilliantly illustrates the real crux of the issue. When we compare what the doctor needs to see versus what they actually see, the gap is just alarming. The doctors treating Chidinma, Amara, and Fatuma are not incompetent. They aren't negligent. They are operating in the dark. Actually, scratch that, it's worse. They're forced to manage a whole human being based on a single, isolated fragment of data. This fragmented picture isn't a failure of medicine itself. It is a massive structural failure of information architecture.
So, let's look at Section 1, the cost of disconnection. Zooming out to the macro scale for a minute, the data shows that multimorbidity, which is having 2 or more chronic conditions at the same time, is incredibly common. Roughly 33% of adults over 50 in Sub-Saharan Africa manage 2 or more chronic conditions concurrently. As populations age and urbanization speeds up, that number is only going one direction, and that's up. That means a huge portion of the population requires coordinated care across multiple specialists. And the complexity scales up incredibly fast. Among those older adults managing multiple conditions, an estimated 40 to 50% face polypharmacy. This means they're taking 5 or more medications simultaneously.
Every single time a new medication gets added to an uncoordinated regimen, the risk of an adverse interaction increases exponentially.
Which leads us to this absolute jaw-dropper of a statistic. An estimated 10 to 20% of hospital admissions in the region are due to adverse drug reactions. Stop and really think about that for a second. Up to a fifth of hospital admissions are directly caused by this fragmented data architecture. These are patients harmed not by their underlying disease, but by the very system attempting to treat them, simply because their doctors couldn't see the full medication list.
Moving on to Section 2, the 5 dimensions of clinical fragmentation.
To understand the mechanics of how this all breaks down, we have to look at 5 compounding structural points of failure that currently block coordinated treatment. First up, the record silo. Every provider holds their own record, completely isolated from everyone else. Second, the medication list gap. Prescribers have to rely on the patient's memory because no verified shared list exists. Third, the drug interaction blind spot. Without a complete list, dangerous interactions are basically invisible. Fourth, the specialist communication gap. Doctors rely on old-school static referral letters instead of shared insights. And finally, lab result invisibility. Crucial tests just sit at one facility, completely unseen by other doctors who desperately need that data to make safe decisions.
Okay, so how do we fix it? Section 3, Building the Care Grid, the AfriPharm solution.
The foundation of this new architectural answer is the Health Vault. What's absolutely vital to understand here is that the Health Vault doesn't just replace local facility records. Instead, it connects them. It creates a single, verified, continuously updated, patient-controlled record. With this, every authorized provider, whether they're a GP in Enugu or a specialist in Nairobi, can finally see one complete medication list and one complete medical history.
Sitting directly on top of that continuous record is Dr. Cheerful. This is a brilliant AI-powered safety layer. Because the Health Vault has the whole picture, Dr. Cheerful can actually read it. It cross-references every single new prescription against the entire verified medication list. It flags severe drug or condition interactions instantly, alerting the clinical team before a patient ever takes the first dose or suffers a preventable hospital admission like poor Chidinma did.
The clinical validation for this is incredibly strong. Research shows that integrating this kind of AI-powered interaction detection directly into patient health records reduces adverse drug events in polypharmacy patients by approximately 30%. 30%! That is a massive reduction in patient harm, achieved simply by giving doctors the technological support to see and analyze the whole picture.
Furthermore, the Care Grid introduces the Virtual Care Network, or VCN. This completely closes that specialist communication gap we talked about. It allows specialists in different cities to review a complete record together in real time. Remember Fatuma? With the VCN, her doctors in Nairobi and Mombasa don't have to be in the same room. They can conduct a multi-provider case conference, view her fluctuating blood sugar outcomes together, and instantly spot that thyroid-insulin interaction that was previously totally invisible to them. Finally, the architecture isn't really complete until the medication is actually in the patient's hands, right? The pharmacy partner network ensures the loop is closed at the most critical intervention point, the dispensing counter. When a patient hands over a prescription, the pharmacist can see the full dispensing history and any interaction flags generated by Dr. Cheerful right there at the counter. It is the absolute ultimate fail-safe before a drug enters a patient's body. Now, what I really love about this comparison is how perfectly it maps a one-to-one technological resolution to every single systemic data failure we've uncovered today. Where there were multiple providers with no shared record, we now have the Health Vault. Where there was an incomplete medication list, we have a verified dispensing history. Where there was a drug interaction blind spot, Dr. Cheerful provides real-time detection. It's a complete structural overhaul of how medical information moves.
Ultimately, what we've seen through the stories of Chidinma and Fatuma is that systemic fragmentation is not caused by bad medicine. It's caused by the absence of the digital infrastructure required to make good medicine possible. When we implement tools like the Care Grid, the fragmented picture ends. Every provider sees the whole patient. Every medication is known, every interaction is detected, and every clinical decision is, finally, fully informed.
I want to leave you with this provocative thought to chew on as we wrap up this explainer. We've seen the devastating physical and emotional costs of operating in the dark. So how many lives will be transformed? How many midnight worries will be eased? And how many preventable hospital admissions will be stopped when we finally give healthcare professionals the complete story? Thank you so much for exploring this vital topic with me today.